Recording now.
Hey, family, what's going on? This is Doug Reed with the Let's Go Show. I'm excited today because I have a special episode. I've partnered with the American Psychiatric Association Foundation, and we're going to take a deeper dive into mental health awareness amongst Black men and Black boys. But I have a special panel for you tonight, and I'll just let the panel introduce themselves. So my first panel guest, please introduce yourself.
My name is Amanda Calhoun, Dr. Amanda Calhoun. I'm a child psychiatrist at Yale. I also see adult patients as well. And I'm also the director and creator of the first ever Black Youth Mental Health series at Yale, with that really could not have been done without the generous support and sponsorship from APA Foundation.
I'm Reverend Jermaine Alberti, and consultant with the APA Foundation, as well as a faith leader and national trainer for mental health first aid, and the co-author of a book called Bottled Up Inside African American Teens and Depression.
Thank you.
Greetings, friends and allies. I'm Raul Andrews. I'm the executive director of the APA Foundation, and I just want to thank Dee Reed, the Let's Go Show family, as well as our esteemed experts here, Dr. Calhoun and Reverend Alberti, for bringing us some time, some insights, and more importantly, some needed energy around making sure that we can start normalizing the conversations around mental health and well-being. But more importantly than that, we can change the narrative, because our numbers are still in reverse at a time when awareness about mental health and well-being is at an all-time high. That's untenable. It's unacceptable, and it's got to change. So enough is enough. Let's go, baby.
Yeah. Hey, Rod, I want to stay there because with the broad reach that the American Psychiatric Association Foundation has in the campaigns nationwide, how does the foundation raise mental health awareness among Black men and boys?
The APA Foundation has been around in this iteration for 33 years. And so we are actively promoting mental health and well-being across individuals and communities. But one of the things that we saw coming out of the pandemic is that there was a literacy gap around mental wellness. And so we launched a national public mental health campaign that has now gone global. We call that Mental Health Care Works. There's a committed website and some other social media presence. The website is mentalhealthcareworks.org. And what we are trying to do is to help people better understand what these terms are that they sometimes hear from their doctors and what it means to them. You know, when you find out that you've been having a really bad day for the last 6 months, maybe that means you need some help. And we want to make sure that people start to prioritize their mental health in the same ways that we prioritize their physical health. The challenge for men is that we don't always prioritize either one until there's a crisis. And so what we have to do is be willing to talk to our doctors, be willing to talk to our loved ones, and get the help we need when we need it, and to see that, Dee Reed, as a sign of strength, not as a sign of weakness.
Yeah, I mean, I totally agree. And I think even recently with I'll say 2 years now, with the implementation of the 988, and I think one thing that's important, and Reverend Alberti, it actually stems around the work that you do. And I'll ask this, tell us more about first aid, mental health first aid. And then the second part of that is, what do you think contributes to the mental health challenges around Black men and boys? You're on mute.
First aid is the help offered to a person who may be experiencing a non-crisis or crisis situation. But it's a public education program also designed to increase literacy around what do you recognize when you see somebody in distress? What signs, what symptoms do you recognize? And so this work has been going on for the past 16 years. And I think what's really important is that people want to act, but they don't know how to act. So they want to help, but they don't know what am I looking at? And so by increasing mental health literacy and reducing stigma is how we do that work. And so when people know what to say, how to say it in a way that doesn't shame and guilt people, but really says, I see what you are experiencing. I hear what you're saying to me, and I'm here for you. That's the work. And I think when it relates to, young Black men, youth, men in general, it's really about dealing with the masculinity of the fact that saying you need help does not mean that you're weak. That's the key thing, being able to ask for help and not threatening your manlyhood is a really big thing. And so I really believe it deals with how we socialize little boys and young men. It begins at a very young age that if you hurt yourself, it's okay to ask for help. Instead, we say, dust it off. Oh, get up. Suck it up. That right there builds a social construct that it's not okay to ask for help, even if you skin your knee. So we need to, even at a young age, let them know it's okay to ask for help, even at a young age, and that there's something wrong with your masculinity or manhood when you ask for help.
Yeah, and Dr. Calhoun, I know just in my experience, when we start talking about traumas that affect men, it always stems back or goes back to the little boy. Tell us about some of the amazing work that you've done in your studies when it comes to Black men and boys and adolescents that you're doing at Yale.
Yeah, so I work with people on the other end of the spectrum, right? So, there's really important work that's needed in getting Black people, Black men and Black boys to access mental health care. So meaning, seeing a therapist, seeing a psychiatrist like me. But I work on the other end of things because I'm usually in hospitals. And so at this point, this person, this child, or an adult, because I work with both, but children, some I've seen as young as 5, are admitted to the hospital because they're in mental health crisis. And what I am trying to do is ensure that when Black people finally do access mental health care, because of all the great work that's being done, they are not further harmed by medical racism. And to sort of define what medical racism is for people who aren't aware, it's a term that, people talk about on different levels, right? So there's like a systemic level to it, racism that happens on a systemic level in the medical system, but also, on an interpersonal level. So there are a lot of racist behaviors that exist in the mental health care system and the medical system at large that we as Black people, especially we as Black people who are descendants of the enslaved and have been in this country for generations, we know about it, right? So we've heard about these things that have happened to many of our family members, right? Being harmed by doctors. And so what I am trying to do is be someone who is helping to lead the change of, after we get Black men and boys to access mental health care, right? They're there, they've made it. We want to make sure they have high quality, equitable, anti-racist care, not care that is further traumatizing them, further putting them into a box, demeaning them, assuming that they're deviant, assuming that they're just oppositional rather than actually struggling. So a lot of my work looks at the other end of the spectrum, and we need both.
That's, I think about it, I was raised in the early 60s. So a lot of incidents in the early 60s with, death of Malcolm, death of MLK, talking about the Civil Rights Act of 1964. And, I'm thinking after all these years, when we start talking about racism, we start talking disparity, that we would go a higher level, and we have, based on the work that you're doing, Dr. Calhoun. But what are some of the major strides that we think racism plays a disparity in us receiving the proper care?
There's a long list of that. I mean, if you're looking, if you're following the research that's out there, the articles that are being released, pretty much across the board, Black Americans are behind. We're suffering. We have worse health outcomes, than white people across the spectrum, right? But race is not real. It's a social construct. So why are we struggling? Not because, Black people are less educated, Black people don't want help, right? I mean, all these things kind of have this underlying narrative that we've had to experience for years of it's our fault, right? But based on the history you're saying and based on what I'm saying, which is that there's a lot of racist behavior that still exists, right? A lot of it has to do with the fact that the care is not the standard of care. So, for example, in this case conference series that APA Foundation has been sponsoring, one of the cases that we did was about a little girl who had been admitted to the hospital. And I have little boys that have been admitted to the hospital. So this is Black children. And, they are acutely wanting to hurt themselves in the hospital. And I'm advocating for them to get increased observation, meaning somebody that's going to sit with them the whole time. And I'm receiving pushback, right? But if a white child comes in, right, and they're saying they want to hurt themselves, they're immediately tended to. With my Black boys, I would say the Black girls get it too, but, my Black boys can't do anything that comes off as, anything emotional, frankly. They hit a wall. Black girls too, but if Black boys hit a wall, they throw a chair, people are ready to physically restrain them. And so what I am doing and what many other people are doing in the healthcare space is making sure that doesn't happen unless it's a last resort. So that parents, families, when they finally do access the mental health care system again, their child is not receiving subpar care. But I think it's important that Black people be aware, which we are, that yes, subpar care does happen. That doesn't mean you shouldn't seek care. It just means you need to be vigilant, right? But walking around this country, going to the grocery store, we have to be vigilant, right? So it's the same thing. You have to eat, right? So you need to take care of yourself and your healthcare how you can. But people like me are there to try to help, right? And to make sure that, okay, well, your child's been admitted to the hospital, I'm keeping an eye on them. And other people who are sort of involved in this fight with me, we're going to make sure they get adequate care. And it's sad that we have to still look into that. But if you look at the data, Black children are physically restrained more in hospitals, right? They're over-medicated more. All these things are a reality. So I very much believe in mental health care. That's why I'm a psychiatrist. I believe it saves lives. I want Black people to seek mental health care if they need it, but I want them to get good care, because it's not fair to say, we want you to seek care, we want you to seek care, we want you to seek care, and then they get there and we don't give them good care, right? Why would you go back? Why would you continue, So I think that's why I say I do see this a lot, just subpar care of my Black boys. I mean, people are scared of them, predominantly white people in the hospital are often scared of them. And so for me, I'm 5'5", I'm not a big person. It's quite powerful for me to walk in there and sit down, next to this young man who might be 6 feet tall, and I'm having a conversation with him. Because then what's your reason for restraining him? I'm not a fighter. I'm not a big person, right? And he's sitting down calmly speaking to me, but you had a problem talking to him. That's your problem, not the patient's problem.
Yeah. And even Reverend Alberti, this raises our stress levels within our families. And I know you do a lot of work, around stress. What are some of your experiences where the stress level has raised among Black men and Black boys?
Well, Dr. Calhoun's story reminds me of when I had to go to Watertown, New York to go to a psychiatric hospital to tend to my youngest son, who was admitted because he was suicidal. And when I went in the hospital, I said, why is everybody who's a patient here dressed in the same color? What does that remind you of? If you want to color code people, color code your staff so we can know who the staff is, and let those who are here for care wear their own clothes so they can feel as if they are not in prison. That was the first recommendation. The second thing I said, they say, well, he won't tell us what's going on. I said, well, if you punish him by telling him he's going to stay here longer, if he don't tell you what's going on, how do you build trust with him if you threaten to punish him for not cooperating with you? And then the other thing that I had to make sure the staff understood that I was not there as his father, but I was there as his advocate. That's what we have to do, equip parents to be advocates, to advocate on behalf of their children, to know that this is not acceptable and that they can speak up. And that it doesn't matter what the doctor says. If it looks wrong, it could be wrong and needs to be addressed as this is not right. And so I think not only do we need to equip parents to be advocates, but communities to be advocates, faith leaders to be advocates. We need more advocates that say to these systems, this is not right. And when we hear about it, we're going to speak up about it. And that right there, I always say to persons with regards to self-care and management, it begins by one, hearing the person who you're talking to. We always come with our own prescribed, our own assumptions, our own cultural stuff that we assume for Black people. And we create these lists for Black boys, this, consider this. It's like, wait a minute, why are you stereotyping? See that person as an individual, not as a list of characteristics. So it really begins by hearing people. And I just really believe in my book that I talked about earlier, you will not help a person until you really hear a person. You have to hear their truth. You have to hear what they're saying. And that's how you engage them. You hear them by meeting them where they are. And once you engage them, then you learn from them and you plan with them. Treatment strategies that don't have the patient's own thoughts about what makes them better, to me, are not effective. So if you create a treatment strategy and you didn't ask me about the treatment strategy that you prescribed for me, it probably won't be very effective. And so I think that the whole self-care piece really is in consultation with the medical community, but then the general community in general that help me maintain my wellness. And so I think that, self-management is great, but it involves community also. Who's going to tell me don't pick up that? Like right now, how we be dieting, we're like, help me, I don't want to eat sugar today, help me with that. And you're like, you can't eat that. The same thing is true with what brings that stress there. So I think that self-management is a part of community management, but also learn how to advocate for oneself and have others advocate for you.
Now, I think you brought up two things I want to key in on. One was self-care and the other was wellness. And I know when we talk about wellness, even, with faith-based organizations, even with yourself, spirituality is a part of that. Why is having a spiritual foundation so important in our overall wellness?
Well, I think spirituality has been proven by science to be effective. We know that people who pray, there's been a correlation between prayer and wellness. So there's this correlation. Unfortunately, there's also damage that's been done by faith in spiritual communities also. And we have to recognize that also. I think that's the important work that the APA Foundation is doing by way of trying to bridge psychiatry and faith communities so that we don't see each other as opponents, or adversaries, but as cooperative entities that have great influence on people. And so I think spirituality is really important. I'm working on what I call trauma-informed theology, where I'm trying to look at how we view sacred texts from a trauma-informed lens, because sometimes we prescribe people stuff, be anxious for nothing. Excuse me, I have a generalized anxiety disorder. What do you mean be anxious for nothing? God's not giving us a spirit of fear, but a power of love and a sound mind. Wait a minute. I'm dealing with depression and all these other illnesses, and you're prescribing scripture to treat something that is ineffective. And so I'm encouraging faith leaders of all faith traditions, look at your sacred text and read it from a trauma-informed lens so that you're not saying things to people that don't help them. Because what you may be causing for me is greater anxiety, because I'm asking the question, like, I did everything I was supposed to do and God is still not here. I did everything I'm supposed to do, and yet that great spirit is not present. So we really have to equip faith leaders and people of faith to be able to look at what is considered sacred and say, is this doing more harm than good?
Mm-hmm.
And it is deliberative theological reflection of what one believes and being able to break that down and go, maybe we should reconsider what we're teaching from a lens that is more sensitive and compassionate and more kind.
Yeah, Raul, let me ask you this. Why is it so important for the APA Foundation to partner with individuals like Dr. Calhoun and Reverend Alberti? Why is that so important based on the mission of APAF?
All of the problems that affect all communities happen in community. The solutions also largely are grounded in the community. However, sometimes the platform and community is not big enough or sustainable enough in order to really get the word out so that the most people who can get the information, the tools, the tips, and the resources can get them as close to real time as possible. And so what the APA Foundation tries to do as the affiliated charity of the largest body of physicians, psychiatrists in the world, nearly 39,000 members in the United States and territories, members in over 100 countries in the world, is we can bring some of that global resource to support local communities. So we're not coming in as an occupier or a receiver. We're coming in to provide assistance, to provide support. And so what ends up happening is Yale's been around for over 200 years. Yale is older than the American Psychiatric Association and its foundation. But when people hear in our community that APA and its foundation and Yale, two pillar organizations in the world, are working together to try to do something in our community, that doesn't mean our ice is colder, but it does probably mean we have more ice than you do. Might not be colder, but we got more distribution outlets for ice between Yale and the APA enterprise, right? So, it's any number of schools that probably wish they could do what Dr. Calhoun's trying to do and will continue to do with our support. But the reality of it is, I think it means something when Yale says, we've never done anything like this before, but I guess it's past time. And we have Doug, as you know, Black people have a very interesting relationship with organizations that start with the name American. Because most of them have bylaws and governing documents where at one point in time or another, women and ethnic minority types people weren't allowed to be members. So the reality of it is, again, when we're reversing, when we're pivoting, I think it matters. There has been research done when it comes to the faith community, and I think Reverend Alberti is spot on. But when you talk to patients and family caregivers on a Likert scale about where they see faith in their well-being and their healing and their recovery, it is a top 2 criteria or component of what they think is a part of their healing, a part of their journey in recovery. But when you go to medical school, Dr. Calhoun can tell us better than anybody else, they're not spending a lot of time with the divinity school about anything about, let's pray it away. So we can't pray it away. We're trying to have faith with work. And Alberti and Calhoun are what faith with work looks like. I mean, the reality of it is, God is not going to heal you if that's, or whoever your almighty is. But if he were to put a Calhoun in your path, and she's equipped and she's skilled and she speaks the dialect and she understands the history of what's going on. So, it's just been Memorial Day weekend and something happened that triggered you and you didn't really feel like you could talk to anybody about it. Dr. Calhoun, not saying that's her lived experience, but that history is not going to freak her out either. Because it's like, well, how could that happen? I don't understand how anything like that could ever happen. We know what our ACEs look like, our adverse child experiences. So I think that's one of the reasons. But I think what's most important to me, Joe, D. Reed, in the 3 years that I've been in this job, this is not to make it light, but this is a team sport. And one of the things that we have tried to make sure, and Dr. Calhoun could tell you if she wanted to about our early negotiations, we haven't asked to pitch and we haven't asked to catch any of the games that Dr. Calhoun is pitching at Yale when she does her series. So we don't see her scripts. We don't ask to see her lecture notes. We don't ask for minutes from her event. And we trust her as a clinician to do what she's supposed to do because she's trying to do the same thing we're trying to do get better health outcomes. Because the one thing we do know when we talk about equity, all of these doctors go to somebody's med school. Got to take some tests to go to med school. Then when you get out of med school, there's boards to take while you're there. Then you try to match into a residency somewhere. All of these young doctors come out and they match to a residency. And then they do their 4 or 5 years of rotation in residency before they become a licensed psychiatrist, physician psychiatrist, right? So how we have health inequity if everybody taking the same boards, they're taking the same MCATs, they're going to the same medical schools, they're going to the same institutions to get training. They come into our program as resident trainees, as fellows, and then they go see the patients, and we hearing horror stories about what Dr. Calhoun shared with us. And I was fortunate to go to a couple of them. And I was very impressed not only with the quality and the caliber of the program that was curated, but the number of panelists that came forward. But I can tell you how powerful this is. The dean of the Yale School of Medicine attended one. I mean, that's how big a deal this thing is. And we have already committed. We haven't figured out exactly how to do it. But how do we keep this going? We want Dr. Calhoun to get her career into stratosphere. But how do we make sure every 4 to 6 months that we're having another program, and some of those programs might not be in Connecticut, even though that's where Genesis was, but we might take it somewhere else and like move as we move around, Doug, you know how I move. But what if we were dropping, this program in Philadelphia? What if we dropped this program in Nevada or Arizona? What if we dropped this program in California next May when we come out there for the APA annual meeting, those kind of things. So we can't do what we do without our physician psychiatrists. But even as much as our physician psychiatrists like Dr. Calhoun can do, unless the patients and the family caregivers trust us to help them navigate their journey, we're never going to get a different result.
Yeah. Wow.
Hey, Doug, one of the things I'm really excited about working with the foundation with is converting our Notice, Talk, Act program and creating a faith-based module to help support faith-based communities being able to notice signs and symptoms, talk about those signs and symptoms, and then act by way of referral. We're all going to talk more about the impact it's having in schools and workplace, but I'm excited the foundation is moving in the direction to equip faith communities with Notice, Talk, Act as a program. We're also retooling our faith guide also to be more diverse and look at how that tool can be used to Notice, Talk, Act with the faith guide. So I just wanted to bring that up, how the foundation is already making those moves to really bridge psychiatry and faith communities. And just like we need to have psychiatrists in our seminaries and in our higher education places of learning, so that the two are bridged, so that faith leaders look to psychiatry as once again, not as a opponent, but as a partner in providing wellness to those that we serve. And so I just really wanted to highlight Notice, Talk, Act, because that is an important work that is happening already in schools and workplaces. And I'm excited about the work we're going to begin to do to take that and make a model for faith communities. So people who are listening to this podcast should know it's coming soon, hopefully, to a faith community near you.
So thank you for saying that, Reverend. Let me just quickly say, Notice, Talk, Act at school has now been authorized by Health and Human Services SAMHSA unit, Substance Abuse and Mental Health Services Administration. We can offer that program free of charge to any K-12 school in the United States and its territory. All you got to do is reach out to us, and we'll provide some information to you, Doug, for post-show so people know how to reach us, www.apafdn.org. But we'll make sure people know how to do that. And then when it comes to faith, here's what I will tell you. If we put 100 faith leaders, non-denominational faith leaders, in one of Dr. Calhoun's sessions, I guarantee you would have a transformative impact, not only on Saturday or Sunday worship that week, but all of the I'm too blessed to be stressed would be gone. Because the reality of it is you can be blessed and stressed. But again, if you stress for a long period of time, there's things to do that can help. And you don't have to just walk around with a sore mind or a sore knee. They both can be treated. But you got to tell us that you need that. And if you do, that's why the Dr. Calhouns of the world are there. And we're so proud of them.
Yeah.
Because it's taken 3,000 years for this branch of the House of Medicine to be seen in its rightful place as one of the originators of the House of Medicine. People just forgot it when they defined primary care as not including the mind.
Yeah,
Let me ask you. I was
sorry. I was gonna say,
because
I would love to see Dr. Calhoun and us work with children and youth pastors.
That would be great.
That's where it begins, right? In children's
I'm
church.
telling you, y'all read
And
my
youth
mind,
church.
and I want to give
That's-
Dr.
that's where it
Calhoun the
begins,
opportunity.
That would be
Healthy
great.
children, healthy youth create healthy adults. And if we can get that health message at a very early age to
Come
children,
on.
you know, and to their caregivers at a very early, and I mean, most people's theology is built in Sunday school. Imagine if we had Sunday schools that were teaching lessons to youth and children about how to care for themselves spiritually, psychologically, physically, the whole person. I mean, that's where it begins. They say that Sunday school is the greatest school on earth. Well, let's make it the greatest school on earth that teaches young people and children and those adults how to care for one another holistically. Doug, I was in your mind there. The spirit was moving. All right, there we go.
No, and Dr. Calhoun, you know we coming your way because, and this is why, because explain to us why the work that you do is so important for the masses.
Yeah, I mean, I think, the sad fact is that, if you think about kind of like childhood, and just what people thought of when they thought about kids. So I looked into kind of like the history of child psychiatry, right? And we're not that old as a specialty because, there was a point in time where people didn't really think kids really were their own entities. They sort of were like, I mean, have you ever heard, kids should be seen but not heard, right? Like the idea that not that long ago that a child would have emotions, right? That they would need to process things that was not something that was really thought about until somewhat recently in this country in a formal way. Now, add to that, so we have that about kids, right? So people are assuming kids can't have mental illnesses. They aren't even thinking about what the child is feeling. It's just like, obey me and be quiet. And if you don't do those things, there's something wrong with you. You're a bad kid. So it was very much like, you're a bad kid, not what is this kid going through, right? And being curious about what that child was going through, generally, right? There are always exceptions. Now, so we have kids in this category where people are thinking they don't even really have mental illness, they don't have emotions. Now let's take Black people, stolen and taken to this country. For the longest time, a lot of white society did not believe that Black people could be depressed. What I learned recently at one of my African American history classes that I was taking for my PhD, literally when Black people are committing suicide on slave ships, they're grieving, they're stolen, right? Obviously, they're in horrific conditions. White people believe that they were just seasick. They said that they could not feel depression. Black people could not feel depression because we were not sophisticated enough like white people, right? So now you're taking Black children, and people already have a problem with thinking about Black children having feelings and emotion. And now you're taking a Black child, transposing the racism that Black people can't feel things. No wonder Black children, Black youth, people aren't thinking about their mental health. So there's a lot that's been ingrained in our minds. There's some conditioning that's happened for us as Black people of punishing Black children, right, to protect them. But there needs to be some reprogramming of, yes, Black children, just like any other child, can suffer from mental illness. In fact, sadly, they can have suicidal thoughts. Sadly, they can be anxious. Sadly, they can have PTSD, right? All of these things, we need to be, normalizing it. Exactly what has been said. It needs to be normalized because it's not to shame parents or to say, you did a bad job. I always say parents have the most difficult job, right? I'm just the child psychiatrist. I just get to go in, play with the kids, observe, and tell you what I'm seeing and work with the parent. But the parent has a child 24/7, right? But it's funny because, the Black church has been extremely therapeutic for the Black community. So it's funny because when I'm listening to sermons, when I go to church, I'm like, I'm learning from them, right? Because a lot of the therapeutic techniques I use in the room with my patients, it might look like a clinic, pastors are using, and they've been using it. So Black people have been getting therapy. They just haven't been getting it in the clinic. Maybe they've been getting it in church. So we really do need to work together because, I can bring in some things that I know, the pastor has many, many tools that they are using, and we can work together to give information, to normalize things, to help people understand, okay, what is a normal amount of anxiety, right? Because some anxiety is helpful. You don't want to have zero anxiety. That's not good, right? There's a level of anxiety that maybe, talking to someone like a therapist or even your pastor is okay. And then there are levels that are dangerous, right? And so understanding the different levels of that, understanding how to take care of yourself in a Sunday school setting, in a comfortable setting where they can ask questions. Because what was brought up earlier was that, to train parents, but even also kids to advocate for themselves. Because I always tell my kids, my patients, ask me all the questions you want, and the parents. If you ask a doctor a bunch of questions and they're angry at you, get a different doctor. I love when my patients ask me questions. I love when parents challenge me because maybe they're seeing something I'm not seeing and they know the child better than I ever will. So I think we can part in the same, I feel the same way about, spiritual leaders, right? But I think we do a lot of the same things, funny enough. We just have different titles. But a lot of the therapy I do, I see in the Black church. So I think there's so much room to work together, and also even normalize things like medications, right? And understanding that like therapy medications don't make you weak. But I think it makes sense why we have a long way to go. I think we've been, conditioned. I think we've been beaten down across generations. And I think for the longest time, Black people couldn't see a child psychiatrist. So we did have to it was like we just had to continue going. Black adults couldn't see a therapist, right? You either figure out how to deal with it or you die. So it makes sense that Black people, the idea of, okay, I can grieve, okay, I can yell, I can come to a person who will hold space for that is new and different because we haven't had that in the medical community. We've had to find that in our own communities. So I think we have a long way to go, but I think we can get there.
Yeah, so important. I think everything is interconnected. And I'll just throw this out to, just to the panel and feel free to answer. Like, what are some ways that we did stigmatize mental health treatment for Black men and boys? And I'll open it to the whole panel.
Let me start here. One of the things that's unique about the Mental Health Care Works campaign is that we outlawed the term stigma. So it is the only public awareness and literacy campaign that we're aware of that is talking about mental health and well-being, and the term is never used. Now, we're not naive. And the reason why we have over 242 million impressions in less than a year on paid media, earned media, social media, and owned media is because we do talk about fear. So we're not stuck on stigma. So we're talking about fear. And Dr. Calhoun describes some things about, sure, you at some point, if you're breathing, you're going to be afraid of something. The question is that fear harmful to you or people you love, right? We do talk about shame. Is your willingness or your unwillingness to go get support, go get help if you need it, or somebody you love needs it, being inhibited by the fact that you're going to be ashamed? We went to a school to do at their request, to do a Notice Talk Act tutorial, just like a little information session. The parents who begged us to come out to the school didn't show up because they thought somebody might say, we got a scarlet letter. If I go to that 7, even though they got some nice refreshments, if I go to that 7 p.m. meeting, that's going to be an acknowledgement that maybe all is not right in my house. And I don't want anybody to know. Now, if we had been doing MCLs and ACLs, the place would have probably had standing room only, people waiting out in the parking lot. You know, the last thing though, and this is why Dr. Calhoun's work is so instrumental, our campaign acknowledges that there is discrimination and marginalization. And so one of the reasons why we do have some of these barriers to care and barriers to seek care is because people are being discriminated against before, during, and after they get care. Or they're being marginalized while they're trying to get care. And so it doesn't take us a lot of times to get burned before we say, you know what, my cousin them tried to do that and they had a bad outcome. And they were asking questions and they got, they didn't have the insight from a Dr. Calhoun to say, if the doctor mad at you because you're asking questions, get a new doctor. That's not what we were told, right? So now, my cousins who had that outcome, that could have been 30, 40, 50 years ago, right? So it isn't like it necessarily was one generation. This could have been 30, 40, 50 years ago that somebody had a bad experience when the science was different, when the teaching was different, when the treatment therapies were different, when the doctors didn't look like or act like Dr. Calhoun, right? So we gotta keep going up the pipeline, working with these trainees and med students so they know not only, we're not saying everybody who comes out of med school and training needs to be a psychiatrist. The reality of it is there are more pediatricians and gynecologists, family practitioners treating people's baseline mental health conditions than all of the psychiatrists in the world. But you got to treat the whole patient because you're treating a human being, right? And that's what we're doing with our training program. So it might be somebody in my ambassador program that's going to be a cardiologist. And I've had cardiologists tell me as I get ready to launch a Hearts and Minds training curriculum that's going to go nationwide probably in the new year. When somebody tells you you got chronic heart disease and I'm opening you up next Thursday, you got to sit with that for a week and a half. There's nothing physical that's going on with you. It's all emotional, psychological, like, wow, here's what happens when we do the surgery, when we crack you open.
You know what, I think
wait, hold on, no.
Yeah.
I know you're scared of it, but I'm gonna tell you the hard truth because I want you to see the emotional. This is what our campaign is doing. When you come out of surgery, it's gonna be a tough recovery, but your life is never gonna be the same. What you do, where you go, what you wear, what you eat, how you sleep, all of that is gonna be forever changed by us working with your ticker. That's if you come out. So you can't run from emotional or psychological well-being, but you don't have to. Yeah. Run to it, don't run away from it.
So let me ask you, so why is it so important for us to start talking about this within our own families? Now, I mean, you said it, Raw, like, we'll talk about it. Well, I have surgery next week. You know, I got to get this, I got this ailment or my arthritis or something is going on, but we don't talk about our families, like things that occurred in our early ages. You know, even for me, like my father was shot and killed when I was 4 years old. Nobody had that conversation with me. I carried that burden for years. So how important is it for us to talk it within our family and Dr. Calhoun at early ages? How do we break that down even at an early age in regards to mental health awareness?
Yeah, I think really embracing, I love the idea of sort of embracing your emotions and running to instead of away, right? And so, you know, I've sat with a lot of kids, you know, who've just cried, or maybe they're not crying, maybe they're yelling, you know, maybe they're, like I mentioned, maybe they punch walls, right? And just giving them that space to do that and saying, whatever feeling you're feeling right now, I want you to feel it. Right. And then, like, I'm validating it and we can talk about it. And just, you know, I think like I said, I think there's been a lot of conditioning in the Black community, because for us to talk about our feelings was not something that we were given the freedom to do. I mean, we could not even grieve properly when we were enslaved. You know, we weren't allowed to grieve, right? You weren't allowed to grieve. You know, in my family, you know, I have people who ended up passing for white and were light skinned like me because of a lot of non-consensual relationships that happened in the South, right? You couldn't grieve that. You couldn't talk about it. It just wasn't talked about, right? And we have so much pain and trauma, and we were not allowed to talk about it because of what white people imposed. So we, you know, learned to just keep it inside. But what I tell people is it catches up to you. It does hurt you. It hurts you physically, right? So we actually have seen studies that Black people may express more what we call somatic symptoms. So interesting, you should say my arthritis is acting up, right? I have pain, I have a headache, I have a stomach ache, right? And I'm like, tell me about what was going on around the time you got a stomach ache, you know? Well, I had somebody pass away in my family. I had a stomach ache. We could talk about that, right? Because the reason why you had a stomach ache was because you were grieving, right? And so I think embracing that and meeting, you know, as Reverend Alberti said, meeting people where they're at. So if you're willing to talk to me about your stomach ache, let's talk about your stomach ache, right? Maybe you're not ready to tell me I'm feeling sad, and that's okay. But the fact that you walk through the door, or the fact we're even having a conversation at all, I welcome that, right? That's the first step. And that's why I say it's very similar to the Black church, where, you know, there's a welcome. It's like you made it to church, you walked through the doors, right? We welcome you. I take that same feeling when I'm working with kids. And so I think, and with adults. So I think that we really have to embrace it, even if people are angry, even if people are upset, whatever they are, and just say, come as you are. Let's talk about it. Or let's not even talk about it. I'll just sit with you. I'll just speak it. I'll just be here. And I think that is so powerful. And we need more of that. And we need more leaders in our community who people can look to for that and can know, I'm not going to judge you. You know, you're not going to, you may feel ashamed at first, but you're going to realize that we're working together. And I have no judgment about you, because we all gone through emotional distress.
Yeah.
But I think we can get there.
Yeah. I mean, time has actually went by.
Yeah.
You know, because we could actually go for hours. But I and Reverend Alberti, I'm gonna come right to you, because, you know, based on our conversation, just some closing comments that, you know, just comes to mind around the conversation.
I was going to say, what I would love to do is have faith communities move from generational curses to generational patterns by way of a genogram, where they laid out their medical and mental history and said, what are the patterns in our family history? And do a visualization of, oh man, there was divorce in my family, there was abortion in my family, there was addiction in my family, there was mental illness in my family. And look at those generational patterns that were there, and then saying, how do we look at these risk factors and now create protective factors to protect our boys, protect our men? We know what the history is. How do we avoid repeating the history by way of knowledge? If we could do that, I think we would make a world of difference in the young men and the boys that we see, because they know their history, they know their story, and they can write their own story.
Man, that's very valid, because we do get that conversation about our medical history. Wow.
We need to talk about our mental history, our medical history. We need to talk about our history, because sometimes there's trauma that we call historical trauma and generational grief that's passed down over and over and over again. And we have to break the cycle.
Yeah.
We have to break the cycle. And
Well,
because we conversations like here, these conversations can break those cycles.
Dr. Calhoun, I come to you for last comment, or that you want to get a listener.
No, I love that. It's actually funny. And it goes back to the theme of that. We're doing the same things, because I was working with the patient and we did that. We did a genogram for her, because it was important for her caretakers to understand why she was having certain behaviors and responding to conflict in a way that was not healthy for her. And I think it was eye-opening because through looking at the generational patterns of the family and the way the family had been set up and had been interacting, we uncovered that there had been some unhealthy ways to respond to conflict that had been happening for generations, along with many strengths, right? And so it was a way to really open everybody's eyes in the family to, oh, so the reason why my child isn't talking to me after we have this conflict is because I don't talk after the conflicts that I have. And my grandmother never talked after the conflicts she had. So I love the idea of us partnering together and doing a genogram that's not only negative, right? It's just informative, and it can harness the strengths, the protective factors and the things that, we should be aware of. But even like something as simple as kids who have addiction in the family, me having a conversation with them saying, you're 10, but I want you to know, you're telling me you have this in your family, you may be at higher risk. So if you get to a point where substances are available to you, if you start drinking, you may not be able to stop, even though your friends might be able to. And the amount of kids that are so astounded by that, because they didn't know, because nobody had told them in the medical field, I'm blaming us, is very high. So there's a lot we could do to help people understand, oh, okay, so if my dad and my grandfather, they struggle with alcohol, this means I may be at higher risk of struggling with it, not through any fault of my own, but just like high blood pressure, just like diabetes, this runs in my family, so I need to be careful. And kids are amazing. A lot of kids take that information and run with it, and it's very protective for them.
Yeah. Raul, you sound like a new initiative, Raul. Closing comment, Raul.
I want to say thank you to Dr. Calhoun and Reverend Alberti for all they've done to bring us to this day and all they'll continue to do to make sure our tomorrows look better than our yesterdays. Doug Reed, I want to thank you for doing part one of this session, and going to ask you later at a different point in time to bring us back for a part two so that we can take the next evolution, but all of us are going to be able to report to your listening audience what more we did together, because D. Reed, you brought us together, and more importantly, how they can get involved in helping change the narrative so we can change the outcomes. There is no health without mental health, full stop. Your body is feeling what your mind is telling it to feel. So if you're in a situation, or you love somebody who's in a situation, or you work with somebody or play with somebody who's in a situation where they having really bad days for months and years at a time, it's okay to go get some help. And if you need some resources of where you might be able to find that help, we want you to start with 988, text or chat 24/7, 365. And if you don't think you're ready to go to 988, what I want you to do is come to the website mentalhealthcareworks.org and just play around with the website, or go look at us on IG at APA Foundation, and just go play with us on the website and see if you find some things that might help a little bit. But these are medical issues, and God bless the Dr. Calhouns of this world who are out there doing it every day, because we need you now more than we've ever needed you before. God bless you all, and thank you very much.
I'd like to thank everybody for actually coming on the Let's Go show with Doug Reed. It was so a lot of information was passed on, and taking this deeper dive into the mental health awareness around our Black men and Black boys. So I truly appreciate you, men and women, for actually coming here to express your expertise, something that we don't get, especially when we talk about the disparity within our medical field. So as I always say, this has been Doug Reed with the Let's Go show. Let's go, baby. Peace. I'm out.